Welcome everybody to this webinar discussion, and we're just waiting for a few more to join us, but we'll let people in now, and we'll just keep letting a few more people in, and we'll get underway in just a minute. So just bear with us while people join us, and we'll then get today's webinar underway. Good. I'm going to let Sandy continue the good job of admitting people and open up today's webinar. I'm Dan Hopewell, the Director of Knowledge and Innovation at the Bromley by Bow, and it's a great pleasure to be with you all today for this very important webinar. And this is really the result of multiple years of work by many parties, and including more recently, the publication of a report that we've written about the role of social welfare legal advice in helping to reduce health inequalities and how it can work closely with healthcare settings, social prescribing, local authorities to do that. And we will be taking you through that report. We'll be taking you through some case studies from the report today, good practice in London, and we will have a panel discussion about the recommendations from the report as well. And we will also be joined by Richard Douglas, who's chair of South East London ICS and who heads up the cost of living task and finish group that reported into the London Health Board last week as well, including around the recommendations of the report as well. I just wanted to start off today by thanking the Mayor of London for the funding for this report and the continued support for this agenda, and the team at the GLA. And we have Karen Steadman and Matt Creamer here on the call today, but others as well within the GLA that we've worked with, such as Gus Wilson and others. The team at Transformation Partners for Health and Care, who I'm part of part-time, but who've also worked with Sandy, who's on today's call, and others, Bill and so on, who've supported this agenda tremendously and worked on this report with us. Sarah Bearden and the team at UCL's Health Justice Partnerships, who've been also working like ourselves on this agenda for many years, and who we collaborate with tremendously, and who supported the editing and finessing of the report, which was fantastic as well. So thank you for that. And some time ago, but really worth mentioning, the work of the Legal Education Foundation, and Matthew Smurden, who also supported this work in some of its early years and continues to support this work with the Health Justice Partnerships team at UCL as well. And many dozens of collaborators who've collaborated with the writing of this report and who have been sort of ardent supporters of this agenda over many years and continue to be so, many of whom actually are also speaking here today on today's webinar. So a huge thanks, and looking forward to working with all of you to take this agenda forwards in the future. Matt, a few words from you before we hear from Richard Douglas.
Yes, thank you so much, Dan. Just bear with me half a minute. Thank you, Karen. So yes, yeah, thank you so much, Dan, and thank you to you, to Morris, to the whole team for the work that you put into developing this report. It's really an important landmark report, I would say, in terms of being able to offer the evidence, B, a set of useful tools, such as the case studies, such as different models of how this can be done. And it's extremely timely in terms of where London is at, in terms of where London's sort of leadership, health leadership is at in wanting to do more in this area in response both to the cost of living crisis that's emerged over the last couple of years, but also the longer term issues of poverty and how the health and care sector can address some of that. It certainly fits in very neatly as well with the lot of the work that the Mayor and London partners, such as all of London's local authorities, have been doing for some time on advice provision, particularly in recent years since the pandemic and the emergence of the 9 recovery missions, one of which was called the Robust SafeNet mission and focused on increasing the capacity and capability of the advice sector to deliver more because of what we saw coming out of the pandemic and the situations that people found themselves in. And that also expanded, not just the capacity and the capability of the advice sector, but also looked at new models of advice provision, such as advice in community settings, really sort of community-centred advice settings. And we've worked with those as well to see how they can build links into health care, because we know, as is explained very clearly in this report, and as we've been working on for a while, to support the expansion of social prescribing, support the expansion of social welfare legal advice in the health and care sector, that the connections between people with poor health, how they slip into poor health, and their economic condition, their housing condition, their immigration status, and the advice they need to support themselves to move on and out of that. So yeah, it's extremely timely. We're really lucky to have such supportive of health partners in London. The 5 ICSs have been really keen and sort of thinking about what more they can do in the sector in this area. And your report, as I say, is extremely timely in being able to support them to think about what more they can do and what more other partners can do around providing social welfare legal advice to Londoners. So I think that's probably enough from me. Dan, I would think people want to hear from others, particularly Richard Douglas, who's been doing a fantastic job at sort of leading the task and finish group from the London Health Board on cost of living crisis. So shall I hand over to you, Richard?
Okay, thank you very much, Matt. And you'll probably been sat there nervously thinking, where is he? And I'm afraid my technology was letting me down when I was trying to work out whether I was Zoom or Teams or something different. But anyway, it's really great to join you all today. I'm delighted to be part of this event. As Matt said, I'm Richard Douglas. I am the chair of the South East London Integrated Care Board. But also as part of that, I also sit on the London Health Board. And I was asked to chair a group on a task and finish group for London Health Board on the cost of living crisis, the impact of that on health, and what we could do about it. And that's really why I've been invited today, and what has really generated my interest here in this subject as a health person, as a health leader. So first of all, I really welcome the report. I think it's incredibly helpful, particularly to integrated care boards and integrated care partnerships, to really focus and get them to think about how they can reduce health inequalities in their areas by improving access to social welfare and legal advice. This is not something we've sort of previously, frankly, thought that much about, I don't think, in the NHS. But it has become clear to us that really these are the areas where, if we want to make a real impact on people's health, and particularly on reducing inequalities, these are the areas we now have to focus as integrated care systems. So we presented our report to the London Health Board last week that set out a number of recommendations, a number of asks of the ICSs, and the timing of this report couldn't really have been better in supporting us in helping think about how we deliver those asks. We've agreed as a group of ICSs across London, and I think probably the only group of ICSs in the country that have agreed anything like this, the principle that everyone who needs it should receive access to social welfare and legal advice, and that we will develop plans from the health side with our partners to help act to implement action to help make that happen. It's a big moment, I think, for health, and this is really, to me, what integrated care systems and integrated care boards were all about was about thinking not just about the delivery of care, but how we can really address the root causes of poor health and how we can do that in a way that complements the work that other parts of both the public sector and the voluntary and community sector to work. And that's, I think, what's really quite different about what we're trying to do now. We recognise, and we've got to be a little bit careful sometimes in the NHS, that we're coming a little bit late maybe to this party. Local government have done a lot of work in this space already. And what we want to do from the health side is think, how can we learn from that experience? How can we build on it? And how can we complement, not compete with, the work that local government are doing, the voluntary and community sector are doing, so that between us we can have a multiplier effect and a real impact. I think this report helps give us the tools for that impact, but I'll be fascinated to hear what people have to say today, and to help us think about how we take this really important agenda forward with real vigor. So thank you, Matt, and I think I probably hand back to you or to Dan at this point.
Great, thank you, Richard. That's really encouraging, and as you say, the timing of this, both in terms of the formation and the establishment of the ICSs and the ICBs and so on, the ICPs, and also, of course, I guess on the other side, actually some of the challenges that Londoners face as well, which are not necessarily easing, but pretty constant. So on both sides. And really helpful to hear your thoughts around sort of how we work together on this as an agenda across sectors. Thank you so much, Richard. I'm now going to hand over to my colleague Maura Farrelly, who is the author of the report, and who, those who I mentioned earlier, some of us work very closely with Maura on this, but Maura is absolutely the person behind the report, and it's a great pleasure to introduce her now. And Maura is going to take us through the main findings of the report and its recommendations, and explain a little bit about how we actually carried out the report as well. So Paul, if you could move 2 slides further on, please, and then just there we go, and over to you, Maura.
Okay, thanks, Dan. I'm just going to quickly take you through my presentation, which covers some of the context of the report in terms of health inequalities and links between ill health, poverty, and financial health. We're going to provide a summary of the key findings and themes from the previous research on this issue, and from the surveys and interviews we undertook for the study. And finally, we're going to do a brief summary of the recommendations from the study. The report is quite long, as some of you may have noticed, and that's partly because it's aimed at a very broad audience of policymakers, health and social care providers, local authorities, the advice sector, and the voluntary and community sector. We hope it will make a valuable contribution to this important agenda, and I'm glad that it's a timely report. And its importance increases in this critical time in the current financial climate. There's a lot to cover in a short term, so I'm going to whiz you through the presentation so that we have time for other speakers. But please note that the presentation will be available after the webinar. So basically, in terms of looking what the overall ambitions of the report are, it was to look at the contribution that welfare advice makes to reducing health inequalities, what opportunities there are for strengthening access to social prescribing, allied to healthcare, and also particularly to social prescribing. As we said, we have a number of examples of collaboration and successful collaborations between healthcare and welfare advice over the past 20 years. The report also has a specific section on the evaluation of the learning from the pilot programme to upskill social prescribing link workers on welfare rights issues. And a major focus on the report is on the recommendations and opportunities presented by the development of the ICPs and ICSs to help coordinated approaches, as highlighted by Richard and Dan. Okay, next slide, please. The methodology of the report included analysis and finding from previous research reports on the linkages between health and social welfare problems. This included studies by UCL on access to justice, and as Dan highlighted, the work of Sarah Bearden and Dame Hazel Genn from the UCL Health Justice Partnership. There was also the GLA commissioned Low Commission report on the health and wellbeing benefits of social welfare advice, and Advice Services Alliance report in 2015 on the provision of welfare advice in London. There are also other research we've looked at. It's obviously Michael Marmot's and the Institute of Health's Equity report on the social determinants of health and the impacts of the cost of living crisis. And there's also reference to research by the Scottish Improvement Agency on advice in GP surgeries, and also research by Citizens Advice. The report was also, and the recommendations were also influenced by the observations from the roundtable discussion in July with representatives from the ICP, the GLA, the health sector, local authorities and the advice sector. Next slide, please. Okay, so when we're looking at health inequalities and the social determinants of health, as you can see from the slide, the map of life expectancy across London on your right-hand side mirrors the deprivation levels across London, the map. Levels of poverty and deprivation in inner and outer London boroughs are increasing, and the healthy life expectancy gap between the most and least deprived areas is also increasing. More than a quarter of Londoners are living in poverty and severely impacted by the cost of living crisis and the lack of affordable housing in recent years. At the same time, there's over £3 million in unclaimed benefits in London. As Michael Marmot has highlighted, if we want to reduce the health inequalities, the greatest focus needs to be on improving the social determinants of health. Why should we treat people and send them back to the conditions that make them sick? Next slide, please. Most of you are very familiar with the concept of the social determinants of health and the fact that socioeconomic and environmental factors are major influence on predictors of potential outcomes. Our survey of social prescribing link workers tells us that over 60% of patients referred by general practice staff needed welfare advice support, in particular with housing issues, money and debt problems, income, fuel and food insecurity, and also immigration and employment rights. Next slide, please. So what is the relationship between welfare advice and the determinants of health? The research or findings from the UCL partnerships have highlighted that welfare rights exist to protect individuals against hardship. Welfare advice services help ensure people's right to support and protection are upheld. This includes benefit entitlement, housing rights, debt resolution, and employment rights. Advice provision is effective in mitigating the worst effects of poverty by increasing the disposable income through benefit take-up and by helping people to restructure their debts or challenge housing disrepair. There is strong evidence from reviews of health advice partnerships that access to timely welfare advice can lead to longer-term improvements in mental and physical health. And the work of urban health and looking at the reciprocal relationship between financial health and multiple long-term health conditions also needs to be highlighted. They have highlighted that despite the systems and support services, they are fragmented and too often treat health and the social determinants of health as separate issues. Next slide, please. So what's the current situation in London in terms of access to welfare advice? The report by the Advising Londoners by Advice Services Alliance looked at the density of advice services identified in each London borough. And as you can see from the map, it highlights that the majority of advice services are in inner London boroughs, but also have extended, there also was some provision extending to outer London boroughs. However, there is no correlation currently between provision and funding of advice service and the level of disadvantage and deprivation, and therefore demand for advice within London boroughs, inner London boroughs, is a postcode lottery with little provision in many areas with the highest deprivation levels, including outer London boroughs. So what did we find? Next slide, please, sorry. So what the research studies tell us was that reducing health inequalities, as we've said, needs to be focused on improving the social determinants of health, which are responsible for 80% of health outcomes. Welfare advice, as we said, makes a key contribution to improving health and well-being outcomes for the most disadvantaged by maximising income, reducing indebtedness and preventing homelessness. The need for welfare advice is increasing due to changes in the welfare advice system and poverty, but the supply is decreasing due to funding issues and particularly from local authorities. Over 45% of London's social prescribing have struggled to find advice services they can refer clients to. This is what they've told us in our survey. Advice, funding and provision is currently a postcode lottery, and this undermines the work of the London ICSs to reduce social and health inequalities. So what can we do to improve the social determinants of health? As Michael Marmot highlighted, there is no single mitigating intervention. Interventions are needed both at a national and a local scale to address some of the broader issues, particularly in relation to the environment and housing. But investing in voluntary and community services, in particularly advice and support services, is an obvious intervention as it offers a high return on investment. Next slide, please. So what is in our gift? What did we find? We found a range of effective low-cost approaches to improving the social determinants of health through healthcare, local authorities and advice services working in collaboration. This included health advice partnerships with GP practices and hospital settings, and there are a number of case studies in the report that highlight these. It also included borough-level dedicated welfare advice teams funded to receive referrals from social prescribing link workers, which will be covered by one of our panel shortly. It also looked at employing social prescribing advice link workers as part of social prescribing or general practice themes. Other examples that were highlighted were successful borough-wide advice provider networks with online advice referral platforms for healthcare, social prescribing and other professionals, which kind of help people not being driven round and round the system. Another key examples from the research were the importance of the training for frontline workers to identify advice needs and provide basic information on how to access advice. Next slide, please. So what else did we find? Some of the key themes were, as we said, around co-location of social welfare advice in both primary and secondary health settings to support the development of service integration that benefits both the patient and healthcare staff. Where co-location is not feasible, outreach or formal referral agreements were another option. Advice partnerships and networks have, as highlighted, help support integration with health and other local services. But the leadership commitment and sustainable resources are required for this coordination and integration to succeed, including referral arrangements and referral pathways. Next slide, please. So some of the other key themes we identified were the training for problem noticers and trusted intermediaries, including healthcare staff and social prescribing link workers, helps to better identify and refer patients with a welfare advice need and has positive effects. Training for social prescribing link workers to provide basic welfare advice has been effective at developing their skills and knowledge and their relationships with the advice sector and should be explored further. The role of social prescribing advice link workers is key in some of this area of driving demand. Despite support, identification of welfare rights problems has been a key need identified by patients. There is no uniform approach across London to how to best meet and resource the patient's needs who are referred by social prescribers. As we've said, examples include local advice services commissioned to take referrals from social prescribers, welfare rights advisors employed directly by social prescribing teams, and more recently, the pilot training of social prescribing link workers to deal with basic welfare advice queries, with ongoing referral and supervision arrangements with local advice providers. So there is a mixture of examples that social prescribing teams can look at, and hopefully the case studies in this report and the information in the report will help social prescribing teams look at what the best option that fits their service is. Next slide, please. So in terms of the challenges and opportunities that the integrated care systems and integrated care partnerships present, but the major opportunity, as Richard has said, is applying whole systems thinking to this ICS development of systems of care and extending the definition of care to include welfare advice as a key service, considering how the integration of welfare advice can be integrated into elements of the care system, and to ensure that accessible, timely welfare advice is targeted particularly at those who are most disadvantaged and suffer the greatest health inequalities. Next slide, please. Okay, there are a range of recommendations in the report, particularly recommendations aimed at the ICS place or borough level at the neighbourhood and PCN levels. As Richard has highlighted, one of these recommendations to create a commitment at ICS level that Londoners should have access to social welfare advice. And we're also recommending that ICP partners will collaborate and commit to funding a level of advice provision to meet their needs. We would like to see advice provision as a key component of integrated care neighbourhoods and plans created for the development of coherent advice provision at borough and neighbourhood level. We recommend that each ICP should develop guidance for the implementation of this commitment, and that the guidance should include encouragement for the formation of borough level task and finish groups consisting of local authority, healthcare, the CVS, advice providers and community reps to take forward the borough level recommendations and assessments and the needs for social welfare advice. We would also recommend it that at place and borough level, that establishment of health advice partnerships is supported, or advice provider networks and referral platforms to help ensure coordinated approaches to the delivery of accessible welfare advice that meets the needs of the most deprived communities. Next slide, please. There are a range of recommendations which we briefly touched on training, ensuring appropriate training of link workers and healthcare staff to enable an understanding of the intersection of health and advice issues, and ensuring effective referral pathways and collaboration to meet the needs of patients. We're also recommending that consideration is being given to the expansion of the advice social prescribing link worker role, and to support the initial training and ongoing relationship with local advice providers regarding supervision and case review to ensure that the quality of any advice provided is accurate. We'd also like to see the development of the role of healthcare professionals and frontline staff in identifying the need for and facilitating access to welfare advice. This could be achieved with provision of regular information to keep people updated with changes in social welfare law, and surgeries with local welfare advice providers for social prescribing link workers and other health and care providers to access advice about specific clients. Development of communities of practice and peer support networks, specifically for hybrid advice link workers and social welfare advisors working in health settings, is also a recommendation. Next slide, please. Other recommendations which are covered in more detail in the report, including embedding screening questions in patient and condition pathways to identify any need for social welfare advice, with appropriate referral mechanisms to advice providers. And this recommendation is based on research of where there is collaboration between either hospitals or primary care, which really supports the needs of the most vulnerable patients, including those with mental health problems, cancer, diabetes, or depression, in terms of accessing advice services and benefits and debt that will impact positively on their health outcomes. There's a recommendation to develop or utilize existing resource material for frontline staff to identify and support people to access benefit entitlements, providing information including take-up campaigns linked to flu clinics, mental health awareness weeks, etc., that will engage both the health providers and welfare advice staff. Obviously, a key recommendation is ensuring that advice organisations are resourced to cope with the demand for benefit checks and assistance with benefit applications and debt problems. Another recommendation, which based on one of the case studies or the findings from the research, was the developing advice provision on benefits, debt and housing for NHS staff as part of a programme to support their well-being and to support staff retention, with a clear understanding of the kind of low-income staff employed in NHS services and in local authority services as well. And finally, one of our recommendations is to utilise the learning from the Financial Shield project on using healthcare and local authority data to identify people who may benefit from welfare benefit and debt advice. Next slide, please. Okay, so that actually is the end of my presentation. I'm going to hand you back to Dan to look at how we take forward some of the recommendations from the report, and to look at how the panel can look at some of the case studies we've highlighted in the report. Thank you.
Great, thank you, Maura, for taking us through that. And it should be said that alongside the full report, which is nearly 100 pages long, to make digestion easier, we have created 5 subsidiary reports, which are much, much shorter. So one looks at making the case, another looks at case studies, for example, as well. Another looks at the recommendations. So we've just drawn out one document just simply with the recommendations and so on. So those are very accessible reports that are much shorter and easier to read than the full report, although we obviously would recommend you looking at the full report as well. So I'm going to hand over now to Ellie De Decker to talk about, and this really is a theme that the team at UCL have been talking about a lot, which is the concept that comes from the United States, is also prevalent in Australia. And it's the concept of healthcare settings, healthcare venues, buildings, such as general practice health centres, co-locating or being built in conjunction with legal practice as well. So that where you go and see effectively the doctor or the nurse is also where you go and see a welfare advisor or a lawyer. It's in the same building. Hence this concept of health justice partnerships, particularly, of course, in low-income neighborhoods where the issues absolutely kind of cross-correlate, and indeed, you know, the one exacerbates the other. So a real logic for the join-up of these two pieces of provision. And not that Bromley by Bow has ever really sort of labelled itself as a health justice partnership. But when I got to think about it, actually, we are a 25-year health justice partnership at Bromley by Bow. So Ellie, handing over to you to talk about some of the benefits of that in co-location and integration.
Yeah, good afternoon, everybody, and thank you very much to Dan and the team for having me with you this afternoon to support the launch of this important report. So I'm the Chief Executive of the Bromley by Bow Centre, and the findings and recommendations in this report very much align with the way of working at Bromley by Bow. And it's really great. And some of the challenges that Maura sort of highlighted very much sort of resonate. So it's really great to see this conversation happening now with all of you and so many of you. Next slide, please. So just to sort of, you know, build on what Dan was saying about Bromley by Bow and the Bromley by Bow model. So just a little bit about that. So the way that I sort of like to describe ourselves is a hub for the community. We're located in Tower Hamlets in East London. And first and foremost, we are a place and a space for people in the local community to come, to be, to connect. We've been around for 40 years now in our local community. And so through that sort of the work that we've been doing, we build deep relationships with local people and local community. And it's those relationships, those deep connections that we build over the years that then make sure that people feel comfortable accessing additional support that they might need. We are based in a very deprived part of Tower Hamlets, and sort of, you know, health inequalities, as Maura mentioned, is something that's very, very real in our local community. So when we are saying that our purpose is for the local community to thrive, that's very much about sort of addressing some of the really significant health inequalities that we see all around us. So next slide, please, Paul. When people think about the Bromley by Bow model, the sort of the Bromley by Bow sites, what people sort of often don't know is that there's actually sort of the coming together of two organizations. The organization that I lead, which is the Bromley by Bow Centre, and we're a charity. And I'll talk a little bit more about that. But as Dan was pointing out, we are co-located with Bromley by Bow Health, which is a health partnership now comprising 4 GP practices, one of which is on our site. And the way that the sort of buildings were construed, where the site was construed, is very much about creating that sort of physical connection between health and charitable activities. And so we're a very tangible expression of health and charitable activities coming together. Next slide, please. So Maura spoke about the social determinants of health and the principles of the social determinants of health. Again, they have been very much at the sort of the core of the Bromley-Babot Centre, the Bromley-Babot model since its inception. So from the start, the way that we've sort of been operating, the way that we've been thinking about the services that we deliver is very much about bringing together health with charitable activities. So that is very much in our DNA, and to a certain degree, we like to sort of say that we were sort of implementing the principles of social prescribing before social prescribing became a thing as such. Next slide, please. Many of the people that come to us have very complex needs. Again, I sort of pointed out that we are absolutely based in an area where there's very sort of long-standing complex social issues. So we sort of really believe that there's no sort of easy solutions, and you can't quite have sort of a single sort of track solution to some of the complex issues that people are dealing with. And therefore, our model is really about sort of person-centered, really sort of trying to understand what really matters to individuals, what support they think is relevant to them, and how they want that support to be accessed by them. So holistic, we sort of see the need for a broad range of services being delivered. And again, as integrated as possible, so that people are not sort of having the sense that they sort of are passed on from pillar to post, but that there's sort of an integrated approach to them accessing the support that they need. Again, sort of these basic principles of that model, we sort of see very much the similarities with some of the principles, obviously, that underpin social prescribing. Next slide, Paul, and you can jump to the next one immediately. So if you sort of think about our model of support, so there's employability, enterprise, and learning. So again, in our local community, people struggle with English, lots of people with English as a second language. Employability rates are very, very low. There's real sort of hunger for enterprise as well. So that's one of the sort of key areas that we do. We provide social care services as well, so adults with learning disabilities, and we're trying to sort of do that in a way that really integrates those services in the sort of other things that we're doing, so that there's a real integration across the community. But the sort of the particular services that I think are particularly relevant for the conversation this afternoon is our work around community health and well-being. So that's our sort of social prescribing work that we do. So we have a team of 8 social prescribers. They provide generalist support, but also rapid response. So that's when there's really urgent needs that need to be addressed. Mental health support, so social prescribing for people who have been referred from mental health services, and then obviously the sort of social welfare advice link worker that we now have. So on the other hand, we also have our integrated advice service. Again, that is a little broad service that we provide, 11 advisors, and they go beyond social welfare to also include financial capability and energy advice. And as you can imagine, we've really seen sort of demand for those services increase significantly over the last 12 to 18 months. And again, to the point that Maura made, one of the sort of issues that we've really been having is that demand has increased significantly, but we've not been able to sort of keep up with from the resources side. So real pressure on resources. And one of the concerns that we then really had was about the length of the waiting times, people who really were in need of support, and us not being able to sort of provide the capacity required. Next page. So as you can see, so for years we've sort of had that sort of social prescribing sitting next to social welfare advice. So that as a concept wasn't new for us, but we sort of felt about 18 to 24 months ago that we really wanted to sort of take this model a step further, and for a number of reasons, again, which is sort of which links very much to some of the things that Maura already pointed out, is that we did absolutely see that a lot of the reasons why people were prescribed, were sort of referred to social prescribing, a lot of the concerns that people raised had to do with social welfare benefits. And on the other hand, when we then started looking at the impact of our social prescribing work, we also found that there was a real potential to make a very significant impact for individuals by addressing those particular concerns quickly. So it was because of the sort of number of people who raised those particular concerns, the potential we felt for making sort of an impact for people really, really quickly, and then married with the fact that we're struggling to sort of refer people quickly enough to our advisors, that we wanted to sort of pilot a more specific model rather than only having the teams sitting next to each other what we wanted to do was actually create a dedicated social prescribing capacity to specifically focus on those particular concerns that people had. Next slide, please. So what we've been doing is, for the last year, we've sort of had one dedicated social welfare advice link worker. And here are sort of some of the stats that you see in terms of the number of people that we've seen. So basically, people are referred in the traditional routes, and then we have a triage service that sort of then allocates those people who are sort of identified as particularly needing that type of a link worker support. And there's some, again, some really interesting stats in terms of why people specifically need referring, and the importance, obviously, of housing and benefits. Some stats as well in terms of the sort of monetary impact of that work, which really makes, obviously, a very concrete, tangible, immediate difference for people in those particular circumstances. And then again, what we're really encouraged by is some very sort of meaningful difference in terms of the self-rated general health and well-being scores. Obviously, we're very interested in comparing that sort of level of impact against the sort of impact of social prescribing, the generalist social prescribing, but it's a bit too early for us to sort of really draw specific conclusions. But we've been obviously very encouraged by the results that we've been able to achieve so far. So then the final points that I wanted to make to the next page, Dan, is around some of the other benefits and considerations. So we sort of really see that in terms of the positives that, again, one thing that I sort of pointed out was that referral to sort of our advisors was sort of hit by quite a lengthy sort of 3 to 4 weeks waiting time. So the fact that there was that sort of immediacy in terms of being able to provide the support was very helpful to sort of keep up the engagement of individuals and families who were referred into social prescribing. We really see benefit as well in terms of our effective use of staff capacity and resources. That it just gives us that little bit more flexibility to sort of adjust as necessary. Again, sort of access to a wider skills and experience base, and we're hoping to sort of see that trickle through to the rest of the team. And something that I know is very relevant for social prescribing everywhere, the ability to retain staff, so people feeling, higher levels of job satisfaction with that. Now, in terms of some of the challenges, so we do need to make sure that there is that continued strong link with the advice team. So our social prescriber dedicated to this is actually supervised by the advice team, because obviously advice, sort of the rules and the legislation is sort of updated quite regularly. So we just need to make sure that the person in that role sort of is really keeping up to breast in terms of the latest developments. And we do still obviously have the need to refer to specialist advisors in the cases, in those more complex cases. So it's helpful, but it doesn't completely eliminate some of the sort of bottlenecks in the system due to low capacity or insufficient capacity. So those are the sort of comments that I was going to make. I don't know if there's any questions at this time or potentially later.
Well, thank you so much, Ellie, and we're going to ask for questions in the chat actually. So if people could put questions, and indeed for the panel discussion that's going to follow Harriet's presentation now as well. So I'd like to now welcome Harriet Plows from Citizens Advice Wandsworth, who's going to talk about really how Citizens Advice Wandsworth tried to go about ensuring an increase in the provision of social welfare legal advice to match the demand and referrals that might be coming via social prescribing in Wandsworth as well, which I think is a really helpful precedent for all of us in London, actually. So over to you, Harriet, and thank you so much again for coming on the webinar.
Thank you very much for having me. So yeah, I'm from Citizens Advice Wandsworth, so coming directly from the advice sector. And I'm going to talk to you about our patient welfare advice service, which has been running for almost 10 years now. So I'll start off just by talking about the need for the project. So next slide. And people have touched on this already, But there's obviously a lot of non-clinical issues that affect people's mental and physical health. So you've got increases in debt, which is causing a lot of stress and anxiety, people in insecure or poor quality housing, which again leads to physical conditions, but also like in people. And GPs are spending time seeing these non-clinical issues and these people coming back repeatedly. And then I guess moving on to sort of some things about our service. And there's not everyone knows about advice services. And in some communities, particularly like migrant communities or people who've immigrated here, there might be either a lack of awareness or a lack of trust in our advice services. But what we do find is people, regardless of other services they're tapped into, will often be registered with the GP, and that is a point of call for them. And then sort of linked to that, you know, the sooner people seek advice with issues, the better. So if you let an issue like housing or financial hardship or debt, if you leave that for a while, it's going to get worse, and sort of there'll be more issues entangled in that. And then in terms of our organisation, something that's worth noting is just, and I think this is true of every single advice organisation in the country, but we don't have enough capacity to see everyone that needs our help. So for instance, it takes 40 minutes to get through on our phone line sometimes. So without a sort of direct referral into our service, patients can get lost, you know, try us once or not call us at all. So if we're trying to reach these people that lack awareness or trust in our services, then it really needs to be a direct connection to make sure that we are able to help them. And then also just with these patients and clients, they need sort of in-depth casework sometimes to help untangle these issues and take action. So I'll move on to the next slide about our model, because I can see some questions about our funding. So the funding structure of ICSs is still a bit of a mystery to me, so I had to email our commissioner to ask this question. But just going, yeah, so we were originally funded by a GP investment fund, but now funded by Wandsworth Place, and they fund 3.2 advisors who take up to 83 referrals a month. And there's 3 PCNs in Wandsworth, so there's 1 advisor for each PCN, and then 1 advisor who sort of deals with overflow referrals. The referrals are mostly made by social prescribers linked to the PCNs, but sometimes they are made by GPs. And clients are contacted within 3 days by a caseworker. And then if they need even more specialist advice, we can refer them internally. Just a couple of things to say. So we usually turn off referrals about 2/3 of the way through the month, because there's always more people the social prescribers want to refer on. But what that means is we've done some work with the social prescribers to help them identify the really urgent cases that would most benefit from support from our caseworkers. And then also to note, as you know, as Ellie kind of said, it's really difficult work that the caseworkers do. So there's lots of untangling of issues. It's sort of very specialised. And with the clients that sort of have the more complex cases or come from the communities that don't use our services so often, sometimes there's a lot of work to do with the clients to help them take action with their issues. So it might be that our caseworkers need to pick up the phone or write a letter for the clients if they're not able to do it themselves. So next slide. So just some of the benefits of this model. So we're reaching clients that might not have been aware of our service and they're getting help quicker. There's direct access to our service to stop people getting lost somewhere along the way. And it's also good for GPs to have a way of helping patients who present with non-medical issues rather than sort of sending them off with a leaflet or something. I think they find that it's nice. An important outcome for our clients is financial gains, as has previously been said. But for instance, in this project, over a 12-month period, we brought in over £500,000 for patients, and that's through sort of benefit claims, grants, backdated PIP payments. So it's obviously that's sort of a very clear metric for how valuable our service is. And then I've put people return to their GP less, which is an anecdotal sort of piece of it. But going on to the next slide, so the National Citizens Advice have done some work on the impact of our advice, and that's some of it there. So we're saying that 50% had their health felt their health had improved, 40% had a more secure housing situation, 60% found it easier to manage day to day. So I think it's clear that help with these issues really does have a big impact on the people that we see. Next slide. And just a couple of things on this. So we've been able to make this work, I think, with a really good relationship between our local ICS. I think they really see the value of this project. At times we've not had secure long-term funding, which has been difficult. I think often our contract has been renewed quite last minute, which isn't always ideal when you've got 3 jobs to consider. And something we're currently working on the sort of balance of is we want to be able to prove the outcomes of this project, but we don't want to spend too much of our advisors' time doing that. So it's sort of a balance between, and I know the NHS is very evidence-based, so yeah, finding a way to easily monitor the impact of our project. And then lastly, I'll just really quickly go through a case study, which is on the next slide. I won't read it out, but just as a sort of typical person that we would speak to, this was someone that didn't know that she needed advice, but she had heard about universal credit and was trying to get a certificate for that. And she was referred through social prescribing to us, and she wasn't actually too sure what help she needed. But we were able to talk to the client and sort of untangle what she needed and what she was eligible for. And with this client, it was us that did a lot of the work that was applying for the benefits to help her and her husband, who was of age and who she was caring for. And for this client, it would have been a fairly significant income gain for her, to put her on a more stable financial. So yeah, that is it from me. And yeah, feel free to get in touch at any point if you've got any questions.
Great, thank you so much, Harriet, and thank you also, Ellie, for those both of those case studies, which sort of highlight examples in London of good practice. I think particularly interesting these 2 potential ways of doing things of co-locating advice and health care together, and we know that potentially 10% of GP practices in London have a welfare benefits advisor maybe half a day a week on site. That's another model that could be developed and expanded substantially as well. And this very close relationship you have in Wandsworth between the social prescribing link workers and the welfare advisors, partly through their kind of geographic identification that your welfare advisors serve a particular locality in Wandsworth and get to know the link workers very, very well, which is really helpful. Now we're going to go over to our panel to talk about the report, its recommendations, and how they see we might be taking things forwards. We're going to leave this till the end, right at the end. We're going to talk about next steps, but just to say that it is foreseen that there will be follow-up work over the next next 12 months to support the consideration and application of the recommendations of the report, both at the ICS level, but also at borough level as well. But I'd like to invite the panel now to maybe give some opening thoughts about this, but also potentially to consider, what kind of leadership is this going to need, particularly at place level, at borough level, to take this forwards, this joined up agenda that Richard outlined at the beginning, really. How do they see this working and creating greater security of provision for Londoners, particularly those who are hardest to reach, of course. So in that panel, we have James Sandbach from Citizens Advice London. We have Tom Barrett, who's from Lambeth Council, Hilary Ross, who is the Director of Systems and Strategy and Development at the North East London Integrated Care Board, and Tal, who's a third sector representative who covers the whole of South East London and is attached to South East London's ICS as well. So really interesting role there, covering all the boroughs in South East London. James, we've got a couple of slides now which just show some heat mapping that Citizens Advice have been doing of one ICS, but we've just chosen one at random, which is Southwest London, but sorry, Northwest London. But it'd be really interesting to hear about that and your thoughts about how to take this forwards, because you've been doing some work pan London, I know, around provider networks of advice providers and referral platforms as well. And then we'll come on to the other panel members, but first to you, James. Next slide, please, Paul. James, I think you're on mute.
Okay, well, thank you, Dan, and thank you for inviting me to be on this panel. It's good to see you know, many so many people come to this event to see what's really the enormous amount of work that's been done on joining up health and advice. And some of you may have come to Citizens Advice's what we call cost living briefings, which take place monthly, which kind of showcase our data, Citizens Advice data nationally that we collect. And I think a lot of this data is very useful for ICS and NHS colleagues to see exactly where health inequalities and how they manifest. And I don't want to kind of overclaim what the data shows. And I think there's always a risk when you put up data sheets that that it gets misread. But because one of the points about advice data is that we only collect what we're able to collect. You know, we so in a sense it's more a measure of supply than a measure of demand, because we can only actually record what capacity, we can only actually record a number of advice inquiries who get through to our system, who get through into citizens advice and get that support. Whereas you know, there's a huge amount of unmet need and unmet demand. But what's interesting is about when we look at what we record is, you know, and we are able to track this on quite a local and borough and ward level, is how much it kind of correlates to some of the work that's being done at the ICS place-based level in terms of looking at health inequalities and where they manifest. So this is, for example, a map of the Northwest London ICS and broken down at ward level to look at all the demand for what we call crisis level support that have really kind of health impacts. So in terms of food poverty, fuel debts, energy debts if living in cold down houses, for people who claim person dependent payments and other housing cost support. And we've mapped that on across Northwest London. We can but then interestingly, if we then go on to the next slide, which is so this is the ICS mapping against the indices of multi-derivation, you can see where some of the hotspots are, and they kind of correlate, but not quite. And there's the areas of need and deprivation that we're picking up in terms of health inequalities that's perhaps not coming through the indices of multi-deprivation. So we have a very rich data set that I think is very, very useful for the health inequalities data researchers who you know, work at the ICS level. And I just think that's that we're very happy to share that data and work with colleagues within the ICS systems. But a lot of what Moya said on from that report really very much resonates with us. There is a lot of very, very good practice and excellent work that's going on, but it is still quite sort of patchy in terms of borough level coverage, and it is at that borough level we need to focus. There are, there's a lot that can be shared across boroughs and good practice, and that I think is also one area where the ICS models can come into play in terms of sharing best practice models across ICS areas. And there are a number of different examples that are, that are quoted in the report, and some of them come from, again, local citizens' advice, but there are also others that aren't in the report, but are also really good examples. So, just for example, you talk about there's possibly a sort of 10% of GP surgeries have some kind of access to welfare on site, access to welfare advice on site, and that's, I think, probably, that sounds to me like a sort of accurate figure from what I know. But there's some really, really good examples of bringing an advisor 1 day a week into GP practice surgery, and it is actually the original model of how this is best done, and I still think it's the best model, and I think we need to see more of that, but it does very much depend on the primary care networks kind of getting engaged in this. So there's something with primary care network level that's important. And the Financial Shield project in Southwark and Lambeth has been referenced, and that is a really good example, and there's quite a lot in the report on that. So I was really pleased to see that. And then also health justice partnerships have been referred to, and I'd just like to make a kind of reflection on health justice, because I think it's we often there's languages around, there's the look at specialist legal advice, but then there's also welfare advice, and there's an overlap between them. They're not always the same thing, and as with all levels of advice, and this is identified originally from the Low Commission report on advice in health settings, you need to see it as being a spectrum. And I think if the focus is too much on health justice partnerships, really health justice partnerships is very much focused around specialist legal advice provision. So legal specialists, and of course, lawyers and legal aid practitioners, they have their own metrics and language for what they use, but the health practitioners have their metrics and language for their use, and often law and health as professions, they overlap, but there's I think some of the language and metrics for capturing outcomes can be so different, they can be quite difficult to combine within single service sort of structures, and there's so I think there's quite an important reflection there. Where one areas where there's there's that one area where outcomes can be captured is through the Warwick Edinburgh kind of health well-being scale, but even that type of capturing of outcomes involves quite a lot of follow-up work with clients, which if you're doing one-off advice, you're not necessarily an advice provider isn't necessarily able to do that. So those are some of my initial thoughts, but I'm very happy to follow up with any colleagues individually who in this call, because I think there's a much more work that we can do collaboratively across London, so there's a bit more consistency. I was reflecting recently, having supported several local citizens' advice in applications for the health inequalities and the health innovation funding, and for the place-based health inequalities funding from ICSs. What we noticed was that the systems for applying and the criteria being applied varied very much across ICSs and within ICSs. So there's, again, something about consistency in terms of where that funding is available, some kind of consistency around how that is rolled out and developed. Obviously, with place-based funding, you need to prioritize, you need to make it relevant to the needs of individual boroughs. But we've certainly found it so different that is there, I think, that we can also look at.
Great, thank you, James, so much. Really helpful indeed. And thinking about evaluation is something also really important as well. So in this, and getting consistencies of approaches of funding whilst recognizing the differences. I'm going to hand, if I may, now to you, Tom, to give a sort of local authority perspective on this, and then on to you, Hilary, and then we'll close with you, Tal, if we may, from the panel. And we'll see if we have some time for further input or not. But Tom, it'd be really interesting to hear from you. Historically, local authorities have been the single greatest funder of social welfare legal advice within their geography. It'd be great to hear from you what your thoughts are around sort of joined up conversations around social welfare advice between health and local authorities there.
Thanks, Dan, and hello everyone. My name's Tom Barrett. I'm the Programme Director for the Cost of Living in the London Borough of Lambeth. And I think I'd just start by saying that I think I can probably speak on behalf of all local authorities in saying that we really welcome the attention that this report is going to bring to this subject area, and the kind of the commitment to the principle that everyone who needs it should receive access to social welfare and legal advice. And I don't need to talk about the cost benefit of advice services. It's been spoken about already here very clearly and well put, and it's also obviously set out in the report. I mean, I think this report is also a really kind of welcome test of what place level system working might look like, and that is in a kind of context of our kind of current financial climate, which I just don't think we can ignore when we talk about some of this. And I can speak on behalf of Lambeth here. As in I think all areas of London, we've seen huge demand for advice that exceeds supply. We've talked about the drivers already here, so I won't repeat any of those. As a local authority, we have increased the budget available for advice services within the council. That's both the what we commission and continuing with an internal team that we have, which we call Every Pound Counts, but also as part of the one-off funding that we've allocated through our cost of living programme, and that I'm responsible for, both through the Household Support Fund, which is the DWP grant that we've been receiving, and the additional one-off funding that the council has identified for this year. I was really pleased to see the case study and the financial link workers financial shield back on track project referenced in the report is a really important one that's been taking place in Lambeth and Southwark over the last couple of years. And I think it's really important to take an appreciative approach when we come to some of these things and when we're developing things at a local level, looking at what works in your local area. That does work, but it's 2 workers in 2 GP surgeries when we have a lot of GP surgeries in Lambeth. There are other things that we've been doing. So we've been providing additional outreach advice on our health and wellbeing bus, which travels around different locations in the borough 5 days a week. Within our community shop in West Norwood, it's identifying all those different community areas where need might arise and where we may need to provide additional support. I don't want to get on my soapbox too much because I need to let other people speak, but I do need to mention the kind of exceptionally financially pressured time that we are seeing for local authorities following the Chancellor's autumn statement last week. We're still not aware, or if anyone else is aware, then please let me know. as to whether or not household support fund is going to continue into 24-25. And in Lambeth, that was £5.4 million worth of funding across London. I don't know what the exact figures are, but it wouldn't be a bad estimate to say that's about £150 million of additional funding to support our most financially precarious residents that will not be in the system. Well, currently, we don't believe it to be in the system in 24-25. And so as we carry some of these discussions forward, we really do have to think about where we manage to identify the funding for additional advice, how we have some of those discussions as a kind of mature system about where we prioritize some of that funding to go, and some of that will need to be on advice, but some of it might be on things like our local welfare support systems and so on. So a really difficult period for us to be having what are kind of complex system conversations already. But I think if you get the right people in the room, those who hold the budgets, who understand the coordination, understand the local systems, have some lived experience involved in the co-production, then that's really important. I think the stuff in the report around training for link workers and the problem notices is really, really important. We put a lot of emphasis on that in our cost of living programme and kind of developing the understanding of the local system. And I think that's the kind of final point I want to make. This is necessarily led at place level, and we need kind of clear and coherent local systems that look across the kind of efforts within that system to tackle poverty, and this is a really key part of that. Thank you.
Great, fantastic. Thank you, Tom. And I think a great segue over to you, Hilary, about kind of what might that conversation look like at place level between, inevitably between health and local authorities. Obviously with advice in the picture, but in the sense the funding is going to probably come from those big two systems partners.
Thank you. And I'm in danger of violently agreeing with everything that Tom has said and much of what other colleagues have said throughout the session as well. So I'm from the ICS in North East London, where some of the most deprived communities in the whole country live. Tackling health inequalities is absolutely a key priority for our integrated care partnership in North East London. We share the really acute financial challenges at the moment in the NHS, as well as combined with really significant pressures around managing our urgent care system through winter, reducing waits for planned care, increasing access for primary care. So it is a really challenging context, but we have managed to secure in North East London support from our board to fund just over 20 million over 3 years to support our work to tackle health inequalities on the back of the national funding that was provided last year. The majority of that funding and that partnership working to address tackling health inequalities sits within our place-based partnerships. So they are really critical to this work. At the system level, we are working. We launched a few weeks ago the Health Equity Academy in North East London, which is really focused on some of the sorts of enablers that we can put in place at the system level around access to data, training and fellowships, and supporting collaboration. But really, the delivery and the action has to be local. We absolutely, like others have said, welcome the London Health Board focus on the cost of living and the report. In North East London, we talk about taking a poverty lens to all of our work. I was looking earlier today, the forecasts about the living standards returning to pre-pandemic levels are now suggesting that it won't be till after 2027, 28 that we will reach that point where back to sort of pre-pandemic levels. But even at that point, many of our communities, families with children, will still be living in poverty. So I think it's really important, and I think this has been recognised, that this work has to be part of that longer term strategy to tackle health inequalities within our systems, and taking that poverty lens and focus to all of the work that we do. I really welcome the approach the London Health Board is taking to this agenda, recognising that each ICS is different and will need to find its own way for delivering on the commitments. Equally, ICBs neither will nor should be telling places how to do this, as it's really important, as others have said, that we understand that communities look different in different places and have critically different assets and strengths and opportunities to build on. We sadly don't have a Bromley by Bow in all of the place-based partnerships across North East London. However, with some of the investment we've made, we are starting to see new innovative developments popping up. The Money Hub in Hackney that has now been established to provide local residents with access to support for benefits uptake is one example of that. That said, I do think, and a number of people have talked today about some of the things that are in all systems and are opportunities to really sort of connect to. So the development of integrated neighbourhood teams, social prescribing, these are fantastic opportunities and really important connection to make in all of our systems, and something that we are actively looking to explore in North East London to help us take this work forward. I think equally there's something about the connection to our workforce strategies as well, and our role as anchor institutions, particularly considering many of our staff are part of our local population. So I think there's a huge amount that systems can be doing to support this agenda. One I would suggest is really critical is supporting the development of the local community and voluntary sector infrastructure. They are really important partners in our place-based partnerships and key to unlocking a lot of this work. Convening partners across our partnerships to provide those opportunities to share learning, to understand what the emergent evidence is like, supporting evaluation and those sorts of things, as well as some of the enablers that I mentioned earlier. So we're really excited to be part of this and very keen to work with Dan and the team to look how we take this forward with our place-based partnerships in North East London. Thank you.
Great, thank you so much, Hilary. That's really, really encouraging, and also a lovely pass on now to Tal to talk about the role that the voluntary sector might play in this. And Tal, we've just got sort of 3 or 4 minutes, if that's okay, before we hand back to Richard for some concluding remarks. I think you may be on mute. No, Tal.
I was going to say you're not on mute, but it must be an issue with the microphone.
Maybe if you just use the microphone on the computer, if there was one. No. No, sorry, Tal. No. See.
Can you hear me now?
Yes, brilliant, brilliant, fantastic, super.
I've done the usual IT disconnect, connect again. It always works. I was just going to say that Hilary kind of stole my thunder a little bit with her summary about voluntary and community sector. A key to anything that integrated care systems are thinking of doing, going to do, and will be doing in the future. So just my role, just very briefly, is quite unique. So I come from the voluntary sector. I sit within the voluntary sector, but my role is fully funded by the Integrated Care Board, so the South East London Integrated Care Board. And the whole purpose of my role is to support our system to collaborate in a more impactful, meaningful and equitable way with the voluntary and community sector. I never call it the third sector, Dan, by the way. We are the first sector. And just in terms of this, because I'm mindful I literally only got a couple of minutes to summarize key thing. I think that if we're thinking, I won't repeat what colleagues on the panel have already said, but if we think about what is key for work like this to happen and for work like this to be at the forefront of the thinking of systems, is that we start thinking of people in a more holistic way, and we think about people rather than patients or tenants, but rather people, understand that people's lives are, people don't live a single issue life. We've got intersecting experiences that will impact everything that a person needs and see, and how they live their lives, and how they then choose to or not interact with services. And I think it is key, in order to really be able to move work like this forward, is that we create within our integrated care systems a really true focus on prevention and early intervention. I think this work sits within that. And if we're thinking about health inequalities, really what they are inequalities. So we need to put social justice lens on everything that we do, and think about what does impact everything that impacts a person's life, and then approach it from a really that kind of holistic way of thinking. And social and welfare advice is key for that, because we know that if people don't have access to this, when they come and see their GP or when they go to the hospital appointment, they won't really be able to engage with whatever advice or information they're receiving, because they're thinking about where they're going to get their next meal from, how they're going to keep their kids warm, where they're going to sleep the next night, So we really, really, really need to create an environment where our sector, so the voluntary and community sector, is leading the thinking, and communities are at the heart of everything that we do. If we do that in integrated care systems, then implementing and having a support like a social and welfare advice will really be a way of doing things, rather than we have to do things specifically to make it happen. So in Southeast London, for example, there is a massive commitment to that. There is a really big pot of money, so 125, I think Richard can correct me if I'm wrong on that, but 125 million over 5 years. And we are really looking at how are we using this money to enable true collaboration with the voluntary and community sector and with our communities, to make that difference and make that impact long term and forever, really. And we've been doing some really collaborative work with the voluntary and community sector and the Integrated Care Board and Integrated Care Partnership in Southeast London, to really bring that thinking together, understand what are the barriers that stopping the sector from playing the role they should be playing. And now we are kind of at the point where we are putting our money where our mouth is and starting to find solutions to overcome those barriers, so we can really, truly take this kind of work forward. I spoke as fast as I could, Dan. I hope I'm still within time.
That was absolutely fantastic, Hal. And also, I think you've sort of talked about something, we've probably been very systems focused in this webinar today, and you've really mentioned a really interesting point. But if this was led by the community or communities, and it had a sort of social justice lens, how would this look? And I think that's a wonderful point to make, and I've made a note of that, and Sandy's been taking notes all the way through the webinar, by the way. Richard, we're going to hand back to you now for your sort of a couple of minutes of closing thoughts before we hand on to Karen Stedman from the GLA, who will sort of help us to think about what some of the next steps are that we hope will happen. Yes, over to you now.
Okay, thank you, Dan, and thank you to everyone who's contributed today. I will try and summarise everything for the last hour and a half, because I haven't got enough time to do that. But just a sort of few reflections, I guess, on this. I think the initial presentation from Maura gave us a really clear picture of the evidence behind this, of really sort of what sits behind the recommendations in the report, and why this is an important agenda for all of us. And draw out the particular bits I draw out from that, the issues of co-location and the issues of training, and they sort of thread through, as far as I can see, through a lot of this. I think I'll take that back particularly. And we got two good case studies, I thought there, two very good and different case studies. I would commend people to read the report as well, because I think you've probably got 7 case studies in there, Dan. So you got 2 examples there. Read the whole thing, because I think the sort of practical case studies are really the way of getting into this subject properly. I think the comments the panel made across the panel at the end, it was some really, this is really very much has to be a local place-led approach. It's got to match. But as an ICS, what we've got to do is support and enable that place-led approach. So it's not saying this is one thing we'll all do, but we'll all support the objectives and enable this. And I see that very much as our role in ICSs and hold us to account for that. So read the report, look at the case studies, draw on this practically in thinking about how you take this agenda forward. But I probably will stop at that point, Dan, and I think do I hand straight over to Karen for sort of the next steps part?
Thank you. Yes, please do. Yeah. Thank you, Richard. Karen, I'd like to invite you in now to talk about sort of some of the emerging ideas around kind of how we might take this forwards and some support that there might be for that. Yeah.
Hi, thank you. Can you see me? I can't see me, but maybe that's for the best. Can you hear me? Oh, yeah, there you go. Just very quickly, so hi everyone. So I'm Karen Steadman. I'm Senior Manager for Health Inequalities at the GLA. So the report and the work with Bromley by Bow was funded by my team. It's part of the Mayor's approach to tackling health inequalities in London. And I suppose, as other colleagues have alluded to, there's been a whole range of work really that the Mayor of London's been doing in this space, working with local authorities, local councils, citizens advice, legal advice trust, to improve access to advice services, to improve uptake of underutilised benefits, so working with a range of partners. And the particular focus of this work, as you've heard, is really, how we can, and really great to see the progress of how we can work together with health partners as well in this space. So it's been a really kind of fantastic journey. And I know lots of colleagues on this call would have been working in this space for a very long time. And I think that's an important point just to flag that while some of this work, particularly the work of the London Health Poor Task and Finish Group, we framed it as being a response to the cost of living crisis. But obviously this is a long-term issue. We've been working on trying to improve access for a long time. The cost of living crisis has obviously exacerbated the situation for many Londoners living in poverty and has pushed more Londoners into that, and has only made this ever more important. That this is improving access to advice services we see as a long-term approach, which is why it's so great to have this really be considered in the context of ICSs as well as a long-term health inequalities agenda. So just very quickly, really all I wanted to say was, informed by the work that's been happening at the Health Board and by the work that we commissioned Bromley by Bow to do. So at the Health Board, there was a specific cast of ICS partners to work together, NHS, local authorities, voluntary and community sector, to reflect on their current approaches and to develop a plan, which the London Health Board has asked for them to bring back in 12 months' time. Aware that everybody is incredibly busy and incredibly stretched, we're trying to help that in the GLA, and we've just uncovered a bit of resource this year to help partners move that forward. So that will be very much building on the evidence we've heard here today. Transformation partners in health and care and Bromley by Bow will be asked to work with sub-regional and local partners to provide support, convene, and largely to help move this along generally and provide this evidence-based support in plan development. I suspect that many of you on the call might be invited to participate in some of that as we go forward. So do keep an eye out, and obviously there'll be a follow-up, I think, from this email, from this webinar, just to share the slides and the report. And just to echo what Richard said, please do use this report, share this report, speak to your colleagues, think about how this might be able to move the conversations forward in your patch, and that will very much complement the work that we're hoping to support as well. So I'll stop there, but a very quick thank you to all the speakers. Thank you to Bromley by Bow for doing this excellent report, which I found very valuable. And thanks to everyone for their interest and support going forward. I'll stop now. Dan, last minute.
Thank you. Brilliant, absolutely brilliant timing there, Karen, and thank you so much for those sort of really supportive words as well. Thank you to all as you've just said as well, Karen, to echo your thanks. Thanks to everybody who's contributed to this discussion today, the webinar today. Thank you to all of those who have helped us with this report and the long journey we've all been on together. This has been an amazing piece of work, and thank you particularly to you, Maura, for authoring the report. We look forward to staying in touch with all of you, as many of you as can, going forwards. This is an agenda, of course, that, as Karen's just alluded to, it's a long-term agenda, been in existence for a long time, lots of people doing lots of great things. How we can support you over the next 12 months to build on the good practice that there is, fill some of the gaps, as it were, ensure greater connectivity between advice and healthcare, and some of the sort of underserved communities in London that face greatest health inequalities, how we ensure that they get the advice that they need, particularly, is the agenda of the next 12 months. And we look forward to taking that forwards with the ICSs, but at borough level as well, and right down to, you know, primary care network level as well. Please do stay in touch. We will be in touch with you. We will send you a copy of the recording, a link to the recording, send you links to the report itself as well, and invite you to continue to work with us over the next 12 months to begin to make, to build on this and to increase the level of support for Londoners. Just one last thanks to Paul, who's been in the background keeping this whole webinar going, and to Sandy, who's been monitoring the chat and who's been also sort of taking notes as well as we've been going along. So thank you both in the background as well. And you know, Sandy was also part of the team that was helping to write the report with Maura and myself and others. So it's been great to be with you. There may be more webinars in the new year. I'm sure we want to keep this kind of conversation going, and keep everybody linking up, you know, pan-London, ICS and borough levels. So you'll probably be hearing from us in another webinar in the near future as well. It's been fantastic to have you with us. We had about 250 sign-ups, and at the peak, I think we had about 150 on the webinar. Some people I know just essentially signed up so they get the recording. They emailed me to say, can I sign up even if I can't come? So anyway, it's been fantastic to be with you. As I say, look forward to being in touch with all of you. And Richard, thank you so much for championing this as well, and for Hilary as well, who both participated in the cost of living task group as well. Thank you for that, and the support from the London Health Board as well. And of course, by no means least, from the Mayor of London. So thank you all very much, and look forward to seeing you all again in the near future. And if you want to get in touch with us, and you know, please do. If you've got questions, queries about the report or the support, then please do get in touch with us. Yeah. Yeah. Bye for now, everybody. Yeah.
Thanks.